I'm going to go ahead. We have the opportunity to learn from Dr. Andrea Taliaferro. And Andrea, I mentioned you in the webinar we just had. And as a collaborator, how long have you collaborated with the CED? Or you have
I've been at WVU for 8 years. So for 8 years, I've had a collaborative relationship with the CED.
Oh, that's great. Yeah. Great. So, Dr. Taliaferro, I'm going to give a bio because it's impressive. So, Andrea is an associate professor in the Department of Coaching and Teaching Studies here at WVU. She received her BS in Kinesiology, Physical Education from James Madison University in 2000. She has a Master's in Education in 2002 and her PhD in 2020. And those were from the University of Virginia. And so what we're very happy that she decided to focus on is adaptive physical education, which you don't hear too often, but it is greatly needed, in my opinion.
Thank you.
Andrea has an extensive academic preparation and experience in areas of adaptive physical education, curriculum, motor development, research methods, and statistics. She holds a national certification from NCPERID as a certified adaptive physical educator and has 17 years of experience working with individuals with disabilities in a variety of physical activities and educational contexts, including schools and community-based programming. And that would include her Friday clinic. I don't know if that's the formal name, Andrea, but that's what we friendly referred it to.
Yes. Yeah, it's got a few names, so that's a great name.
Okay. Very descriptive.
Yes.
So there are various projects that she's worked on, a lot of productivity, including book chapters, peer-reviewed publications, presentations throughout the state, pretty much a leader in this area, both statewide and nationally. So we're very fortunate to have her present Grand Rounds this month. And based on the slide that hopefully everyone can see, she's looking at psychosocial and environmental determinants of physical activity in select populations. So with that, just kind of some housekeeping. I'm going to turn it over to Dr. Taliaferro, but remember to track either your questions in the chat, and Andrea, I'll track those. Since you have your desktop, it's tough to see that.
Thanks.
And otherwise, at the end, we'll leave a few minutes for people to ask questions. So in the meantime, please mute your phones, and we'll get started.
Great. Thank you so much. And thank you for having me today, and I appreciate everybody joining as well. So today I wanted to take some time to discuss with you some of my research, but some research as well, looking at psychosocial and environmental determinants of physical activity in populations of individuals with disabilities. As Leslie shared, my background and experience is up there, but really what I wanted to share is that prior to starting my PhD, I taught general PE for a year in a public school system in Virginia, and then I spent 6 years teaching adapted physical education within 3 different school systems in Virginia. So really my research interests and my experiences really stem from my time as an adapted physical educator and general physical educator in the public schools. What I wanted to do today was share with you some research in the area of minimizing health disparities through inclusive physical activity. And specifically, I'll be talking about 3 areas in which I research. The first is teacher self-efficacy toward teaching individuals with disabilities. The second area looks at teacher, instructor, and coach preparation toward including students with disabilities and athletes with disabilities in community-based physical activity. And then the third one focuses on barriers and facilitators to inclusion in school and community-based physical activities. Sorry, let me forward. So, like I said, during my time teaching, it really became apparent to me that the successive inclusion of students with disabilities in physical education was related to the attitudes of the teachers. What I was finding is that teachers who had more or higher attitudes and better attitudes toward inclusion really put more effort toward inclusion of students with disabilities. So my interest in this area of teacher self-efficacy really began during that time. And up to the point where I started my PhD, there had been quite a few studies looking at physical education teachers' attitudes towards students with disabilities. But the problem with these studies was that they were mainly atheoretical. They looked at attitudes and confidence, but not really from a theoretical standpoint. So I decided that I wanted to investigate this concept, but from the framework of self-efficacy theory. So I'm sure many of you are familiar with self-efficacy theory, but just as a quick overview for those of you who aren't, self-efficacy theory basically is the study in looking at a person's beliefs in their capabilities to successfully perform a task. And self-efficacy is situation and context specific. According to Bandura, there are 4 sources of self-efficacy. And through these sources, we gain information about our self-efficacy in a specific context. So the first source is mastery experiences. These are individuals' experiences and prior experiences performing a task. And these are the most influential set of self-efficacy experiences that there are. The second is vicarious experiences. Vicarious experiences are when you observe somebody performing a similar task or somebody with similar experience or skills performing a task, and then you make a judgment of your abilities in relation to their success or how unsuccessful they were. In terms of social persuasion, this is feedback that you gain from other individuals about your abilities. And then physiological states are how you feel physiologically when you're performing a task. So if you're nervous, happy, or excited, for example. What I really liked about self-efficacy theory, in particular looking at inclusion of students with disabilities, is that the theory states that those with higher self-efficacy are more likely to persist when they're faced with challenges and more likely to also overcome challenges. So I was interested in studying this, but unfortunately at that time, there was no instrument to actually investigate teacher self-efficacy. So for my dissertation, I undertook the creation and validation of an instrument to look at teacher self-efficacy toward inclusion of students with autism. And the purpose of the study was to determine the reliability and validity of that developed instrument. It included 5 subscales. The first looked at self-efficacy beliefs toward inclusion of students with autism. And then the second subscale looked at the different sources of self-efficacy. So how successful were individuals' prior mastery experiences, including students with autism? What have they seen other people do, and how successful were other people they observed? What had people told them about their abilities, for example, and so on. The third subscale looked at teacher behaviors. So how frequently or how often had they performed these behaviors when including students with disabilities, things like modifying equipment or modifying their communication. And then also perceived challenges. So how successful were they, or how much of a challenge did they find different things? Again, self-efficacy would say that those with higher self-efficacy perceive fewer challenges and actually are more likely to have done the behavior. And then a scale looking at demographic factors. And thankfully that all actually came out valid and reliable, because then I was able to use it in future research, and it's been used by quite a few individuals now in quite a few different countries, the resulting instrument. But for example, one study that I did here at WVU, we were looking at the self-efficacy beliefs of pre-service physical educators toward inclusion, and really looking at if a combination of coursework in adapted physical education and hands-on practicum would influence their self-efficacy levels. So in this study, we were looking at, again, if their participation in an adapted PE course could improve pre-service physical educators' self-efficacy beliefs toward inclusion over time, and whether these changes differ depending upon the course. We investigated students' pre-service teachers' self-efficacy beliefs in relation to 4 disability types: autism, intellectual disabilities, physical disabilities, and visual impairments. We used a repeated measures design using convenient sampling of intact groups, and we surveyed the pre-service physical education teacher education students who were between 2 courses. So course 1 is a pre-major adapted PE survey course that all of our pre-major students in physical education teacher education complete. And then course 2 is a senior level adapted PE course. The students in course 2 have previously completed course 1. And both of these courses participate in a on-campus practicum as a part of their course, which Leslie referred to before as the Friday program or the Friday clinic, in which we bring students with disabilities onto campus Each semester we bring about 80 to 90 students with disabilities onto campus, and the students within these two courses work with the students in both the gym and the pool. We use two different instruments to collect the data, and we surveyed students in the first week of class, about midway through the semester, and about halfway through the practicum, and in week 15 of class. And results found that students' self-efficacy beliefs significantly improved across time for all 4 of the disability types. So from the beginning of the semester to the end of the semester, we saw significant improvements in student self-efficacy toward including students with autism, intellectual disabilities, physical disabilities, and visual impairments. But the only significant difference between courses was found for autism in time 1. And actually, interestingly, in looking at the data from time 1, students in the pre-major course actually had significantly higher self-efficacy beliefs toward including students with autism than those in course 2. And that's an interesting finding. You would think that students with more experience should have higher self-efficacy beliefs, but actually this can somewhat be explained or is in agreement with self-efficacy theory. Self-efficacy theory states that if you don't have experience at a task, you're likely to originally overestimate your abilities in those areas. And it's very possible that students in the pre-major course, many of whom have never worked with students with disabilities or even taught any students before that, may have overestimated their abilities at the beginning of the semester, and then eventually perhaps their self-efficacy beliefs became more realistic as they gained that mastery experience throughout the semester. Okay, so continuing in teacher education, and similar to that research, there is much recent research that shows, if I can get this to go forward, there we go, sorry about that, much recent research that shows that hands-on experiences and practicum in adapted PE are essential course components within undergraduate physical education teacher education programs. However, the problem in looking at all of the research out there is that there are no two practicum experiences that are alike. So while we see that it is often the case, a lot of programs have on-campus practicum, some programs have off-campus practicum. Programs like ours, our students work with 10 to 15 students with different disabilities, but in other practicum programs, it's not unusual to see them paired up one-to-one. So basically what we see in looking at research on adapted PE practicum is that they're often limited to providing students with exposure rather than fostering the development of teaching or coaching skills. That attitudes of pre-service teachers can really widely vary based on the quantity and quality of the practicum experience. And there really is to date no consensus on the scope of practicum, the structure, design, or purpose of AP practicum within undergraduate PE programs. So to dive into this topic a little bit more in teacher preparation, I undertook a study with a colleague here where we looked at a Delphi investigation to determine essential characteristics of effective undergraduate physical education, adapted physical education practicum for pre-service physical educators. Our participants in here, let's see if I can make it a little bigger. It's not going to let me, so I'll just talk through it. Our participants for this study included 24 identified experts in the field of adapted physical education. In round 1, experts were asked to respond to a prompt, an open-ended prompt, and the prompt asked them to identify one essential characteristic of an effective adapted PE practicum. So they were brainstorming ideas. We originally received 70 recommendations from round 1 of characteristics of an effective adapted PE practicum. In rounds 2 and 3, the same participants then rated each of the items in importance and feasibility on 7-point Likert scales. After round 3, we ran the data, and there were 47 items after round 3 that were rated above a 5.0, which you can kind of see here on this chart in the middle. See if I can, oh, sorry, never mind, go back. In the middle is kind of a scatter plot with importance on one side, feasibility on the other. And at this point, we decided that any item under 5, we weren't going to move forward in the study. And 5.0 on the importance scale represented moderately important, and on the feasibility scale that represented probably feasible. So we really wanted items that were both important and feasible to implement in undergraduate adapted PE practicum. We ran a thematic analysis on the resulting 47 items that were rated above 5.0 on both scales, and we came up with a few different themes, the first one being context. Second theme was teaching and learning activities. The third theme third theme was outcomes and soft skills, and the fourth theme was evaluation of instructor performance. And with these remaining 47 items, our intention was to create an inventory that could be used to evaluate adapted PE practicum within undergraduate PE programs. So I'll take you kind of through a few items here on the resulting inventory. Basically, our idea with this inventory is not necessarily to look at if it's yes or no, does a program have this in place or not, but to what degree do they have this component in place. So the first theme, again, is context, and under context, we have some items looking at program organization. So does the program provide opportunities for college students to learn through trial and error in a safe, supportive environment? Recommended minimum of 30 hours of contact with individuals with disabilities, and multiple practicum experience provided over the course of the undergraduate program, not just a single experience. For program setting as a sub-theme, items such as does the practicum program provide direct interaction with and observation of practicing adapted physical education teachers? Does it provide experience in an inclusive general physical education environment? Is there direct interaction with and teaching learners with disabilities? And opportunities for observation of teachers implementing lessons, modifying activities, and engaging with participants. The third sub-theme under context is learner characteristics, and these really look at opportunities to work with learners of a variety of disabilities and a variety of ages. The second theme, teaching and learning activities, had a few sub-themes as well. So the first was assessment. So does the practicum provide opportunities for students to experience conducting assessments that are appropriate for physical activity and education? Do they develop IEPs and goals based on learner assessment data? And do they assess and analyze the results? For example, under the sub-theme of planning, experience with planning, basically writing lesson plans, designing and implementing lesson plans that are meant to address individual and unique needs, and developing and implementing developmentally appropriate programming that's sequential. Under skill-centered instruction, some items include observing and teaching a diverse selection of physical activities and sports, and performing a task analysis with respect to locomotor and manipulative skills. And then effective teaching practices. Does the practicum provide pre-service teachers with opportunities to provide developmentally appropriate feedback, use a variety of effective teaching practices, and experience managing and motivating learner behaviors? Part 3, or the third theme, is outcomes or soft skills. These really kind of look at opportunities for professional development and reflection and communication, as well as collaboration with other service providers. And then the last one, evaluation of instructor performance, looks at if students within the practicum are receiving, and teachers within the practicum are receiving constructive feedback and supervision during their teaching in the practicum. And our thought with this and our next plan for this instrument is actually to go and start assessing and having others assess their university practicum, so that we can really get a good idea of what is going on across the U.S. when it comes to adapted PE practicum within undergraduate physical education teacher education programs. Okay, so area 2, the next area, I'm sorry, area 3 actually, really looks at barriers and facilitators to community-based adapted physical activity. So I want to talk a little bit about a study that I did a few years ago here in West Virginia. It actually was funded, thank you, through the CED. One of my students wrote up a graduate student grant to receive money to conduct this research. And the purpose of this study was to identify barriers, facilitators, and needs influencing physical activity participation of adults with intellectual disabilities within the framework of a social ecological model. During this study, we took a qualitative approach. We collected data using surveys and guided focus groups with both individuals, adults with intellectual disabilities, and their primary caregivers. Our participants included 6 adults with intellectual disabilities, ages 23 through 38, and their primary caregiver, who happened all to be their mothers, 6 females, ages 40 to 70. And we drew our participants from 2 different metropolitan areas in the state of West Virginia. some of the results when we looked at barriers, we really found 3 categories. We found that there were a lot of organizational barriers, individual constraints, and external influences. For example, under organizational barriers, a lot of the organizations in the area, the biggest issue really was resources. Funding, a lot of it came down to funding. Some opportunities that existed because of funding, participants were restricted that they could only participate in 1 or 2 programs a year due to funding. Information dissemination was actually found to be another big barrier. It was found to be very challenging for individuals with disabilities and for their parents to find information about existing programs. Even when that information existed, the channels to distribute that information really were challenging. So a lot of the parents and the adults with intellectual disabilities discussed that when they were of school age and they were in school, they received a lot of that information on physical activity programs in the community home from school. They received flyers, they received announcements from school, but since they no longer were in school, they no longer had that channel or that avenue for information dissemination to learn about programs. There were some policies that were restrictive. So for example, many of the adults with intellectual disabilities stated that when they were younger, they had participated in many different physical activities, but as they got older, a lot of the organizations had age limits or age restrictions on activities, so they kind of aged out of those activities, and there was no replacement activity as they got older. And then ease of access, especially in our area and in our states, sometimes it was quite a distance to get to the existing physical activity programs, and transportation was an issue as well. Under individual constraints, motivation and skill of participants with intellectual disabilities was probably the biggest barrier. Many of them were actually very motivated to try and participate in physical activity, but because of things like their reliance on others for transportation or others, including their parents, to help find and identify physical activity programs and wellness programs for them, that became a barrier. And time and work constraints actually was a very big barrier as well. All of the adults with intellectual disabilities in our study worked, so many of them said they would like to participate in additional activities, but they just had to check on their work schedule or they had to figure it out around their work day, which became a constraint. And then in terms of external influences, caregiver considerations really came into play. So a lot of the caregivers really noted that they really promoted physical activity for their children, for the adults with intellectual disabilities, but because of constraints of the caregiver, they were kind of limited sometimes in their options, including time constraints. Many of the caregivers worked, so they could only transport their children to activity programs outside of the workday. Many of them had other children and other responsibilities, so they had to make decisions on how to get each of their children to physical activity programs. Sometimes health of the caregiver became a barrier. For example, there was one mother who participated who said that she and her child, who is an adult with an intellectual disability, used to enjoy swimming. And they went swimming a lot, they went swimming every week, but then she developed a shoulder injury and she could no longer go swimming. So because of that, her child also no longer went swimming either. Safety limitations were a concern, and some were extremely true safety limitations. They were medical considerations that needed to come into play. But interestingly, there were some safety limitations that were perceived safety limitations. For example, there was one adult with an intellectual disability who was sitting in one room talking about her physical activity, and her caregiver was in the next room, and the caregiver was sharing how much she encouraged physical activity for her child, how, every day she was encouraging her to use the treadmill, and they signed up for a bunch of different physical activity and wellness opportunities, and she really wanted her to do more physical activity. But meanwhile, the child was communicating to us, or the adult with an intellectual disability, her child, was communicating that her mother actually told her not to do physical activity and not to run and jump because she didn't want her to get hurt. So the message that was being sent to the child was different than the message that the parent perceived that she was communicating to her child. And then an imposed choice of activity. Many of the caregivers said, well, my child probably doesn't really enjoy this activity, but because I do it, I make him or her do it as well. So some parents said, the only time I get to work out is if I bring my child with me to the gym, so because of that, they have to go to the gym with me and work out and use the treadmill as well, even though they don't like it very much because that's what I wanted to do. In looking at facilitators, and there were quite a few of them, the parents and the caregivers really were champions for their children, for the adults with intellectual disabilities. They really fought to make sure that they were included in physical activity. They really fought to find available options for their children. And other facilitators were camaraderie. The participants with intellectual disabilities loved being around each other. They had gone to school together, they participated in a lot of programs together, and they really found that camaraderie through participating in physical activity and wellness programs. And then through some needs and ideals that were expressed for future physical activity program considerations. So the first was family program involvement, that programs really needed to consider how to involve families and not just participants with disabilities in their programs. For example, one parent expressed, you know, when I take my child to a physical activity program, they get their physical activity, but I don't because I'm sitting on the side watching. So sometimes they had to make a choice between their physical activity or their child's physical activity. So some suggestions were that programs consider how to involve families, whether at the same time or in separate activities. Some improved programmatic structure, particularly in terms of communication and organization, and then programmatic support. Many of the adults with intellectual disabilities expressed that they needed some additional support to participate in some of the programs, and particularly inclusive programs, whether that was additional prompting or physical support or just assistance changing in the locker room, for example, that provided support would really be useful to improve their opportunities for physical activity. In comparing the results back to the social ecological model, what we found were that the barriers and facilitators to physical activity that we identified applied to, transcended, and interacted across all levels of the social ecological model. But in agreement with a lot of prior research, the barriers and facilitators that most impacted physical activity for adults with intellectual disabilities were found to be at the organizational level. So it's not going to let me zoom in a little, and I'm not sure why. I apologize on that. But at the organizational level, while the other barriers existed, there were ways to overcome those barriers. And adults with intellectual disabilities and parents had expressed ways to overcome those barriers. But the organizational level barriers were really the ones that were restricting participation in physical activity. So for example, things like limited resources and restricted participation rules and policies, problems with dissemination of information, and age appropriateness of some programs. So some individuals said, you know, my child really liked participating in the soccer program, but as she became older, you know, they brought in clowns and balloons every week, and it really wasn't age appropriate for somebody in her 30s, so we stopped doing that program. So a lot of the reasons why individuals with disabilities were stopping participation in a lot of these programs really were the barriers at the organizational level. Further investigating barriers and facilitators, there are a few other barriers that exist that are found in the research related to community-based physical activity programs. The first one is lack of knowledge and training of instructors. So when we think about community-based physical activity programs, sometimes these programs like Little League and soccer, gymnastics programs, many times they're run by individuals who don't have a background necessarily in teaching or coaching. Many times they're run by volunteers. Here in the Morgantown area, we have a lot of programs that are run by coaches and instructors that are college students, and they may not have the knowledge and the training on how to work with individuals with disabilities. Many times because of that lack of knowledge and training, there is fear or concern of liability of the program leader, the parent, and the child. If a parent isn't sure that the instructor or the coach knows how to work with their child with a disability safely and successfully, they're probably more likely to reconsider signing their child up for that sport or activity. And of course, a lack of appropriate programs further compound the issue. So worked with some colleagues here, and the purpose of this research that we did was to identify and systematically address the barriers to physical activity for individuals with disabilities in ways that target their sources of self-efficacy. And the model that we proposed was entitled the empowerment model. The empowerment model is a tiered continuum of training, support, and programming. And the aim here is to move individuals from a direct level of training, support, and programming down to an indirect and eventually to an independent level if possible. There are three continuums. So in the training continuum, a direct level of support would mean direct training of staff and instructors within physical activity programs. We've termed these strategies of success modules, but basically some training modules to train individuals on how to include students with disabilities or participants with disabilities. An indirect level of training would look like an individual who is trained, who we have termed a mentor or a helping hand, and that person would attend the programs and help to provide some feedback to the instructors or the staff members to help improve inclusion of participants with disabilities. And on the independent level, we would hope that eventually staff and instructors would be able to move down to more reflective teaching, in which they're able to become aware of their training needs and indicate and seek out training in those areas. On the support continuum, a direct level of support would provide support to the child or participant within a physical activity program. An indirect level would provide support to an instructor of the program. And then an independent level, hopefully we'd be able to move the child down to an independent level of participation and move the instructor down to kind of a consult basis where they can seek out the resources and help when they're needed. And on a programming standpoint, the continuum ranges from specialized programming that's geared just towards individuals with disabilities, down to reverse inclusion programs in which we have a program that was basically geared towards individuals with disabilities, but we bring in individuals without disabilities to participate in those programs as well, to an independent level in which individuals with disabilities are included in the typically existing community-based programming. Now, the key with this tiered empowerment continuum is that these levels of training, support, and programming can kind of be mixed and matched across the continuum. So, for example, you could have an instance where staff of a particular program, like a gymnastics program, might receive direct training on how to include students with disabilities, and then a paid mentor or support person goes to that gymnastics class and provides support to the child, and that's run within an inclusive community-based gymnastics program. Or you might see something like indirect support provided to a child in which a trained individual goes and helps kind of co-teach or support the instructor within an adapted aquatics program, a specialized program just for people with disabilities, in which an individual who is trained goes and provides feedback to the instructors. So we've done quite a bit of work on this module, and we have a few projects running off of it. So one project that we have put this model to work in was a grant that I had funded for 3 years by the National Inclusion Project. And this grant was a partnership between our lifetime activities programs here at WVU and, of course, the National Inclusion Project. Our lifetime activities programs are community-based physical activity programs that are operated by WVU's College of Physical Activity and Sport Sciences. And these are classes that are open to anybody in the community. Per year, they run an average of about 125 different classes, anything from dance to taekwondo to swimming, and they have an average of 2,000 participants. Prior to our partnership with the National Inclusion Project, the participation of individuals with disabilities in all of these programs had been very limited. So the director was only aware of 2 participants across all of the programs who had identified disabilities. So in thinking about why we didn't have a larger percentage of individuals with disabilities participating in these existing programs, we sat down, we kind of did a bit of a needs assessment, and we came up with these particular issues. The first was limited inclusive community-based physical activity opportunities, a lack of awareness and information dissemination, a lack of support necessary for participation, and a lack of staff training. So we decided to implement the empowerment model within the lifetime activities programs with the support of the National Inclusion Project. The programs that we decided to target were the most well-attended children's programs: swimming lessons, basic gymnastics, and the National Youth Sport Program Summer Sport Camp. The project goals were that all LAP, Lifetime Activities Program staff and instructors in those 3 targeted programs would be trained on working with individuals with disabilities. We would also train and hire mentors, and these are individuals with some sort of background in adapted physical activity, and they would be hired to provide support to participants with disabilities and instructors within the programs. Often what this wound up looking like was a trained individual would attend the gymnastics program or the swimming program with a participant with a disability to provide them and other participants extra support when necessary, and sometimes it looked more like the mentor being kind of a second teacher within the group to give a kind of a higher teacher to student ratio. And then our last goal was to improve promotional materials to highlight the inclusive aspect of the lifetime activities programs. So 2015 was our first year, and during this year we found that we were able to increase the percentage of participants with disabilities in our programs from less than 1% prior to the partnership to about 7.7% in the summer programs and about 12.9% of participants in the fall programs. During 2015, in the summer and fall, we had 12 unique participants with disabilities who filled 24 registration slots, and we were able to train 100% of the staff within those 3 targeted programs. In 2016, we were able to increase participation. We went from 12 unique participants to 23, and they filled 36 registration slots, so many signed up for more than one activity. We had between 5.6 to 25% of the participants in gymnastics had a disability, 11.8 to 16.7% in swimming, and 8.6% of participants in NYSP summer camp had a disability during our second year. During this year, we had ongoing mentor support, but we also were able to have increased awareness, marketing, and communication strategies, including social media. In 2017, we again increased participation, although we didn't have quite as many. We went from 23 to 22 unique participants, but they actually filled 46 registration slots this year. So they were signing up in more and more activities because parents were becoming aware that our instructors were trained and they knew how to include students with disabilities within the programs. So we found that we had about 11.7 to 21% of gymnastics, 10 to about 13% in swimming, and 10% of participants in NYSP summer camp had disabilities in 2017. At the end of each program, we would solicit parent feedback and a written survey. And these are some examples here of parent feedback. Things that kind of warm your heart a little bit, like the second one. My son always wanted to take a gymnastics class but never could due to his disabilities. Now, due to the inclusion project, he can do it and feel included. Okay. Other feedback dealt with increasing children's confidence and making them feel proud about themselves for being included among kids without disabilities. And more feedback. Parents really came to appreciate the support. They really came to establish both the parents and the participants relationships with the mentors and the instructors. Many of the instructors and mentors have continued to work year after year and really develop those relationships with the participants and parents. But parents, this feedback was also given by parents of children without disabilities who really noted that it meant a lot to have an integrated program that promotes awareness and acceptance. And this was actually my favorite one. I hated this question, but we were required to ask this question by our funding agency. Did you know prior to enrolling that children with disabilities were included in lifetime activities programs? And we got a response from one parent on the survey that said, no, I've not seen any kids with disabilities swimming at the same time with the other kids. And in this particular class, this person's child was enrolled in, there are actually 6 kids with disabilities participating in the inclusive swimming classes during that time. So to me, the fact that a parent of a child without a disability doesn't notice that there's any kids with disabilities participating means that the support, that inclusion is being done well. There's enough support, there's training of the staff, so that everybody is participating and challenged at their own level within the program. Okay, next project that we're continuing to implement the empowerment model within is a grant that I was fortunate enough to recently have funded with colleagues at James Madison University and Bridgewater University, both in Virginia. And this was funded by the Virginia Board for People with Disabilities, and it again aims to implement the empowerment model. Our grant has 3 kind of goals and 3 strands. The first strand is training, so providing basically constructing and providing online training modules for staff and instructors within community-based programs in the Shenandoah Valley. The second strand of support, the grant aims to provide both direct and indirect support, including equipment, to our partner organizations within the Shenandoah Valley of Virginia. And then the third strand is that programming strand. And in order to fill in the gaps and run a continuum of programming from self-contained all the way to inclusive programs, we have formed the Shenandoah Valley Inclusive Wellness Coalition. And the coalition is a group of about 70 members right now, comprising organizations, within the Shenandoah Valley, mainly fitness, recreation, and wellness organizations, as well as individuals with disabilities and family members of individuals with disabilities, also teachers, instructors, and therapists. And their goal is to enhance inclusive community-based program opportunities in the Shenandoah Valley. So we're just wrapping up almost year one of the grant. We have most of the training modules done. We're about to pilot the training modules here, and we're getting our partner organizations on board for direct programming going into year 2. So we're again going to kind of evaluate here the effectiveness of the empowerment model. And then lastly, this is kind of a different project that I've undertaken here in the past about 3 years, but this project was aimed to kind of counter one of the issues that we often see in inclusion within physical activity and sport, which is resources and equipment. So a lot of times we see barriers like funding, financial considerations, including the increased cost of specialized equipment and assistive technology, and many times individuals are unaware of the available assistive technology resources, especially within a physical activity setting. So one solution that I've explored is a university-school partnership. School-university partnership is defined as a collaborative venture across the preschool through 12 and college-university communities as vehicles for the discovery and sharing of knowledge that shapes educator leadership and best practice. So this school-university partnership is actually between us here at WVU and a high school robotics team from a town in New Jersey. Their name is the Pascack Pioneers, and they actually are a robotics team from the high school that I graduated from in New Jersey. And this all came about a few years ago when I was actually back visiting where I grew up, visiting my parents. And there was an article in the local paper talking about the Pascack Pioneers, first robotics team, and that they just won this international or national tournament for robotics. And included was, there was a little video online that I went to go watch, and they had created for the competition this robot that shot basketballs. And the first thought that went through my mind is, that's really cool. I need that in our Friday adapted PE program. So I called up the school and I called up the vice principal and had a nice conversation. And he knows what I do, but I explained, that I ran this practicum program for about 80 kids with different disabilities, and that I saw what the robotics team had put together, and I thought it would be really cool if we could work together to get some sort of assistive technology for use in our adapted PE practicum. So I worked with the robotics team for about 3 years. These kids were amazing. It's amazing what they know how to do. And they were able to develop a robot. Basically, we started with a robot that kicks a soccer ball. So they developed different prototypes. They pilot tested a bunch of prototypes, and last October, they came down and delivered a robot for use in our Friday program. The current robot has a push-button activation switch, but over the summer, they actually created a few more switches to help activate the robot, and they're currently working on an eye gaze system as well as different robots. So I'm going to try here and share a video of the project. Hopefully the sound comes through with it. Hopefully it loads, or not. Let's try that again. Okay, it doesn't seem to want to work today. I apologize. So the video is just going to take you through the different steps. So if anybody's interested in watching that video, it's the video that they put together for promotional opportunities. I'm happy to send that link to you for the video. So this relationship is continuing. They're looking to build more switches. They're also looking to develop more robots. But what's most exciting to me is that they're looking to actually build this robot into a kit that can be made available to other programs and other universities across the U.S., as well as schools and other physical activity programs, so that they can put this together at low cost. And the cool thing about it as well is that there are many FIRST robotics teams across the U.S. There's actually one here in Morgantown that I didn't even know of until this partnership. So the Morgantown area robotics team is actually on board. They service the robot for us. So it's possible for ideas like this to be shared and implemented across the U.S. And this robotics team, the Pascack Pioneers, is really into developing those ideas and sharing the resources so that other teams can replicate this robot for use in their communities. Okay. And that's all I had for today. So I'm happy to answer any questions and open it up to questions. Any questions?
Sorry, I was on mute.
Okay.
Okay, sorry, I was muted too. Andrea, how do you go about recruiting participants and getting the word out about these inclusive opportunities?
I'm sorry, could you repeat that one more time? I kind of got disconnected a bit.
How do you go about recruiting participants and getting the word out about inclusive opportunities?
Sure, particularly with the Lifetime Activities programs? Yeah, so we've done a lot through the social media on the college website. I do send stuff home with participants in our Friday program, so information does go home through the school. The Lifetime Activities programs that we focused on are mainly for school-aged participants. We do need to expand it, I think, to adult activities because there are a bunch of those as well. But we found that the school has been a useful avenue for that, as well as social media. And honestly, surprisingly maybe the thing that we found that was most useful really was word of mouth. It kind of, in year one, took us a bit to get, I hate to say it, but to get parents to trust us and use their kids as guinea pigs in year one. We didn't have as many participants originally sign up as we initially had thought we would. And we actually wound up having one particular participant enroll. And after that, like, the floodgates opened, a lot of people were interested. And what had wound up happening was this particular parent had posted information about our program on her website and on a website, I guess, in town for parents of students with autism. And when everybody heard that she signed her child up, they all decided, and one other parent actually said to me, oh, when Mrs. So-and-so signs her kid up, the rest of us sign our child up as well for things. So that word kind of spread once we got into the community and into the kind of the parent groups. But I will say that I think information dissemination is still a barrier and still an issue, both for participants with and without disabilities, actually, within our programs.
Andrea, can you hear me?
Yes. Can you hear me? Yes.
Okay. Many of the individuals on our team are providing additional services, and we have identified health and wellness as one of our areas. What would you recommend to them in terms of connecting families with types of resources to encouraging physical activity?
Yeah, it's a good question. Hopefully I'm able to answer your question. If not, please redirect me. I think some things that are particularly needed in terms of health and wellness and to get in touch with families and get them involved are programs that do include parents and family members without disabilities as well as their family member with a disability. In the one study that we had done, a lot of the parents expressed, as I had mentioned, that they didn't get their physical activity because they spent all of their time running their children around and taking their child to physical activity and wellness programs, and then the parents wind up sitting and watching. And while sometimes they appreciated the break, they wish that there had been an opportunity for them to participate as well, either alongside their child or maybe like in a parent group where they could do some yoga or some other fitness activities. We've also found in the Lifetime Activities programs that a lot of the families that enroll kids with disabilities also enroll their children without disabilities. And they've mentioned that these are the only programs in which their children can participate alongside each other in the programs. So I would say that some strategies really have to focus on activities that are available to participants with disabilities as well as their family members without, which also helps with the marketing because then you have two potential markets that you're trying to advertise to for the activities. I don't know, does that answer your question a little bit?
It does. Thank you.
Okay. Thank you. Yeah, of course.
I'm trying not too much because of the echo. So can you see the chat?
Yes.
Okay, I'm typing something there.
Okay. Okay, I see the chat, but that's all I see. I didn't actually see anything.
Oh, it hasn't popped up.
No, it hasn't popped up yet.
Okay, so sorry about this.
Oh, you're good.
I was just going to say our state has developed a plan for physical education.
Mm-hmm.
Are your efforts included in that?
It's a good question. Our state also is the first to have a statewide physical activity plan that does include quite a bit of information on including individuals with disabilities. In terms of the physical education plan, I have not necessarily been heavily involved in that, unfortunately, and I think our state is maybe a little behind when it comes to adapted physical education within the schools in terms of training. I don't think we're unusual in terms of states, but there are, currently there's 14 states that have a separate teacher certification for adapted physical education, meaning that you have to have a statewide certification in adapted PE, not just in physical education, to teach adapted PE. There are only 14 states with that. West Virginia is not a state with that. And unfortunately, a lot of teacher training programs only have very limited coursework and preparation in adapted PE. So I don't know that it's heavily reflected in the state physical education plan and curriculum. Hopefully we can get more of an emphasis in it, but I think awareness is one of the things that does need to be improved. I am personally only aware, and I could be totally off on this, but I am only aware of 2 adapted PE specialists within the state of West Virginia. So I think that perhaps our lack of focus on it is potentially reflected as a lack of focus in the plan as well.
Wow. Okay.
Yeah.